Today we're going to talk about dementia, point blank blunt. What to do about it, how to prevent it, and how to improve it. The big takeaway that I hope you'll get at the first part is that it's happening younger and younger. So despite all of our supplements and all our sort of nutritional knowledge that we have as a population, it's not working. Something is backfiring. Something is very incomplete. And we're going to explore that because I don't want you to be just another statistic. Certainly not another statistic at 25 or 35 or 45. So I call this is a new face of dementia today and how to avoid it with these strategies. The new face is younger. What are these strategies? How do they improve a person's cognitive impairment? Why is cognitive impairment happening earlier, younger and younger? And who's most at risk? Let's get to it. So the age of diagnosis is getting younger and younger. These are faces you've probably all seen, except for the one in the middle, who's diagnosed at age 30 with no genetic predisposition. What we know so far about increasing incidence of dementia, Alzheimer's, and cognitive decline. We're not going to get too deep into neuroanatomy, but I think you need to know this. Healthy brain is on the left and a atrophied, a demented brain is on the right. And what we're going to call this is basically shrinkage. So extreme shrinkage, severely enlarged ventricles, which are where the cerebrospinal fluid comes into the brain, and extreme shrinkage of the cerebral cortex. That's what you need to know. It's not just the hippocampus, it's the whole brain. Healthy versus unhealthy. Memorize that. We're going to get back to it later towards the end to get into it again. Okay, the other thing you need to know, hippocampus is right basically dead center in our brain. Here's the cerebellum that has to do with balance. I'll mention that coming up. This is all the cerebral cortex. That's about as much as I want you to know. All right, I told you it would be quick. So among the 10 leading causes of death nationally, Alzheimer's, i.e. dementia, is experiencing the sharpest rise. And this is just since 2000, over the last 22 years, 20 years we'll say. In 17 years, increased by 150%. That's the rate of increase. It's not a per capita, the rate of increase. Projected Alzheimer's disease prevalence, 2000 to 2100, so that's 100 years, is just going to be huge. It's going to go up by 500% from 2000. So from 5,000 per capita cases in the thousands to 25,000. And it's worse for women, and it's getting worse for younger people. So the rate of dementia has increased over 700% since 1980. Since 1980, there was an inflection point of dementia, of Alzheimer's, of mild cognitive impairment, whatever you want to call it, it suddenly started to grow. So the question is, and I put this down, notice, does this graph look familiar? 1978, late 70s, going up, men and women. Here's what I hope that you will remember from past videos. It all changed in the 1980s. This is relative to obesity, but it's the same graph for Alzheimer's, dementia, cognitive impairment. And of course, blood sugar is one of the variables. I'm not saying all dementia is obesity, all obese people are going to have dementia. No, but it's a variable. But the important point, the inflection point is identical. The inflection point of when these cases started to increase quickly was identical. And we need to go back and really need to know what happened so we can change that in our own lives. So this isn't a cultural thing I'm talking to you about. I'm talking to you about changes that you're going to make because it's in your best interest not to become demented or have mild cognitive impairment or become Alzheimer's and have everybody else take care of you. So you're going to live to 105 and be healthy. That's the goal here. So, all right, what I wanted to show you was, in previous videos, we talked about the two studies that were carried out from 66 to 73, the Minnesota Heart Study and the Sydney Diet Heart Study at the same time. So it all changed in the 1980s. Before that, we ate basic food. We all had basic food in the 60s, kind of when I grew up. Then you had to clean your plate of that. But after that, it all got to be different. It got to be convenient. We call it processed food, but let's go a little deeper on that, okay? Here's a study from 2013, just the titles. We're not going into it deeply, but it says something. Omega-6-3 ratio, we've talked about, and dementia or cognitive decline, a systematic review on human studies and biological evidence. So it says they looked at 14 human studies And they found a positive association between the 6:3 ratio and the risk specifically of Alzheimer's, specifically of dementia, specifically of cognitive impairment. Okay, linoleic acid in the US. So the amount of omega-6 fatty acids in body fat has increased by more than 200%, threefold in the past 50 years. So let's go back. The ratio is supposed to be 1-to-1. That's what it was 150 years ago. So by the time when they were fighting the Civil War, even though that's where things like Crisco got started just after that, the ratio of all the fats that they had was 1-to-1. If you took their blood, if you took out a fat biopsy, would be 1-to-1. The same amount of omega-6 would equal the same amount of omega-3. That is no longer the case. We're as high as 25 that I've seen in the clients and patient population that I've seen. And it's a factor. It's a factor that can be changed. So I'm perseverating on this particular point a lot because it's very easy to change. I'm going to show you that. So excess omega-6 associated with conditions of depression, obesity, cardiovascular, cerebrovascular. Now, the opposite, the deficiency of omega-3 is associated with obesity, depression, dementia, Alzheimer's, multiple sclerosis, neurological, right? And chronic inflammatory conditions. Two common myths about Alzheimer's and cognitive decline, and that is that they're age-related, and therefore, well, it only happens to old people, and therefore, hey, we're all going to get it, aren't we? No, that's not the case. AD, Alzheimer's disease, is a true disease with what they call the fibrillary tangles and the tau plaque and so on and so forth. Not getting into that. That is an actual disease manifestation. We're talking about pulling back Alzheimer's considerably, dementia, cognitive decline, mild cognitive impairment. 2, Alzheimer's disease is all in the genes. That it's all genetic. It's not all in the genes. In fact, it's less than 1% of the genetic mutations they have uncovered so far, and there's a lot, but only less than 1% of all of them have anything to do, or to flip it around, only 1% of all cases of Alzheimer's, dementia, cognitive decline have anything to do with a genetic predisposition. So it's on your shoulders to pay attention to this information to change your life so you don't get myth number 1 that it's all going to happen to you as you get older. Okay? What causes cognitive impairment and Alzheimer's? How can it be prevented? The big picture regarding the causes of cognitive impairment, dementia, and so on, is that it's multifactorial, of course. This is more or less an illustration of what I just said. These are non-genetic risk factors, which you can modify. Many genetic contributions of very small effect. Now, a lot of people don't like hearing this. A lot of people don't like hearing this because it makes them have to carry the responsibility of their own health. And I've seen this in people who've come through my doors to seek my services. They want a genetic answer that they can go, God, I can relax now. It was never my fault. Well, it was never your fault in the first place, so don't cop that attitude, but there's plenty you can do about it. It's just like environmental exposures isn't your fault, but learn about it and be careful about it. You don't have to be excessive about it. So the point here is there's plenty of modifiable risk factors to diminish or improve your cognitive impairment, improve your Alzheimer's, improve your dementia, or prevent it all altogether. Okay, healthy brain versus a true disease. This is a diseased brain. Hippocampus, it's almost hardly functioning. So we've been through this before, and we're going to call this basically the shrinking of the brain. And one of the most profound shrinking that most people notice initially of their partners or their parents is the shrinking of the prefrontal cortex. That's the thinking part of the brain in the sense of allows you to converse and make sense and communicate. It's pretty much right there. As that starts to retreat and become smaller, that's when you start noticing it. So this is just a slice to make it pretty simple. So we need to stop the brain from shrinking. In order to do that, we need to avoid the things that cause the brain to shrink in the first place, right? We're all on board? Okay then. You know, it doesn't take long to go from a diagnosis of cognitive impairment to dementia. Once you have cognitive impairment, and assume you're really not going to be doing anything, and by the way, there are no known medications that are actually all that effective. There's plenty known medications that are ineffective for all of these things. They're not effective. But 5 years from cognitive impairment diagnosis to dementia, full-blown dementia. So what are the factors that shrink the brain, right? That's the question. So let's start here. Top 5 deficiencies that shrink the brain. Omega-3, vitamin B12, vitamin B6, folate, not folic acid, and vitamin D. So now that you have the answer, it's a little more involved than that. One is how B vitamin deficiencies lead to brain atrophy, shrinking, and cognitive impairment. This is a good diagram I like. Basically low folate status, low B12 status, cognitive impairment, but what it does, it increases your homocysteine. And so elevated homocysteine, which is a lab we're going to look at in a second, is a good sign that somebody's on their way to cognitive impairment, but it's also an easy target to adjust and change. So the higher the plasma homocysteine, that is the lab levels, were, the faster the observed brain shrinkage rate, and the more effective was the B vitamin treatment. In other words, they're showing the greatest deficiency. They're showing the greatest need. And by showing the greatest need and treating it, they have the deficiency, they will improve the most. If they don't have a homocysteine problem and they're taking all sorts of, and then you start giving them or they start taking B vitamins, there's not going to be that much improvement. So we're looking for this. Okay, mild cognitive impairment. MCI confronts 5 to 20% of Americans aged 65 or older, as most of the data has demonstrated. The risk is higher among people who have a high level of the amino acid called homocysteine. I know you've never heard that before, right? High homocysteine and mild cognitive impairment both predict higher risks for developing full-fledged Alzheimer's. What patients might discuss with their physicians? Now we're giving the issue out. People always ask that. Well, my physician doesn't know all this stuff. Well, it's up to you to bring him these issues. So if you have MCI or a family mild cognitive impairment or a family history of mild cognitive impairment, dementia, or Alzheimer's, consider measuring your fasting level of homocysteine. If homocysteine is high, also then measure B12, folic acid, which is the name of the lab, and B12 and B6. If homocysteine is on the high side, discuss whether or not you should add moderate doses of B12, 6, folate, not folic acid to your supplements. Plasma or red blood cells levels of omega-3 oils can be measured specifically by specialty laboratories. And if on the low side, consider increasing your intake of fatty fish or adding a fish oil supplement, which is what we showed you before. And I want you to know it's the combination of having adequate omega-3, remember the omega-3 index, adequate omega-3, a good ratio, and low homocysteine, which basically means you have good B vitamin status. To say the obvious, fish oil is fat and B vitamins are water soluble. So you run out of the water soluble vitamins much more quickly than you do fat. Caution. Although the B vitamin doses used in the studies were moderately high and typically thought to be safe, there have been reports that high blood levels of folic acid might increase the risk for some cancers. We've covered this before. In the 800 microdose of folic acid used in a Vitacog, we'll be talking about the study coming up, it's only double that of current recommended dietary allowance. However, other vitamin formulas used to treat homocysteine often contain considerably higher folate doses. Most nutritionally oriented physicians prefer that people take the natural methylfolate form of this vitamins. I used to say folate from food, folic acid is supplements, and usually medicines. Not the synthetic folic acid that most vitamin supplements use. See video on folate versus folic acid. Other studies basically say the same thing. So I'm trying to give you a big consensus out there that is not being told to you. So the percentage of the population that has MCI, dementia, Alzheimer's, due to elevated homocysteine, low B vitamins, or low fish oil is about a quarter, 22% is what they estimated here. There's a study on it, and there's other studies. Okay, regions of the brain that are protected by, that use B vitamins. Your whole brain doesn't use it, so it's very specific of certain areas. Notice the hippocampus is down there. It's a big area that needs the B vitamins. So where do you get B vitamins? Ideally, I hope you're thinking of what foods are high in B vitamins. And that would be, covered that in the previous video, liver or egg yolks. And so if you're thinking about what supplements to take, I prefer you to think about, and it's much in your best health interest to think about what foods are high in those specific B vitamins, which usually come together as a package, you'll find. But on to the next. B12 is within normal range. Here is a really interesting thing. This is all normal range. This is the normal range. When you take any lab, you see there's a range. So this is the normal range. But look at from top normal to bottom normal. Serum B12 is related to the rate of brain atrophy, shrinkage. So this was 107 community-dwelling elderly, not impaired at baseline. And they tracked them for, I believe it was over 5 years. That's right. Percent change in total brain volume per year over 5 years. So within 5 years, their brains shrunk. And they measured this. The brain volume changed over the normal range. And no one was B12 deficient. But they got really granular. That's why you really need to look at the data, not just check. I did the B12 check. What was your number? Know your numbers. Sorry if this is a little responsibility put on your shoulders, but it's also very exciting, very liberating to know you can take charge. No B vitamins equals big atrophy in 2 years. With B vitamins, little atrophy. With B vitamins, little to no atrophy. And you can see, here we go. We're looking at the hippocampus. We're looking at the hippocampus. Without the B vitamins, oop. With the B vitamins, not much of a difference. What about fish oil? Omega-3s. Glad you asked. Okay, here's a Norwegian study, cognition in the elderly, intake of fish, and what they basically say, here again, here's the range. At the top range, we're doing quite fine. And this is episodic memory score. So they're basically cognitively impaired and they're ranging it. So what we're talking about is get to the high range, grams of fish per day. Grams of fish per day. They could have been more specific, don't you think? Was it salmon? Was it cod? Okay, so omega-3 fatty acid treatment in 174 patients with mild to moderate Alzheimer's disease, and there is no beneficial effect on cognition in this study of supplemental omega-3s, 2.3 grams per day. Apparently, the trial failed. But wait a minute. Here's the value of looking at all the data. Some did improve, but not as expected. It was only in just those patients with low homocysteine, right? So low homocysteine, meaning they had adequate B vitamins. They already had low homocysteine. We don't have to worry about that part of the equation. These people, when you added in the omega-3 treatment, with these people, the omega-3 treatment did slow the decline of cognitive test scores. The omega-3 fatty acid needs to interact with B vitamins in order to prevent, to restore, to improve brain atrophy, shrinkage. In other words, the goal is to have higher amount omega-3, greater than 2.3 grams per day, and have a 1-to-1 ratio of omega-6 to 3, and a homocysteine low, best within the 5 to 7 range. Let's take a look. Here's a statement saying, Alzheimer's disease can be prevented. It's not a genetic disease. So I'm not selling you my wishful thinking. It's pretty much documented. And this goes back to 2014. So that's 8 years ago. Signed by 111 scientists, 36 countries. Estimated about half of the Alzheimer's disease caused by known risk factors, and that taking immediate action might prevent about 1/5 of new predicted cases. All right. So the VitaCog study is called vitamins. That's right. Vitamins, cog as in cognition. The VitaCog study, what it showed is omega-3 fatty acids only appear to protect the brain in people with low homocysteine, that is with good B vitamin status. B vitamins only appear to protect the brain in people with good omega-3 fatty acid status, so it's just the opposite. These unexpected interactions could explain why some omega-3 trials have failed and why some B vitamin trials have failed. And this is what's been put out there in the press. Omega-3s didn't work to reverse cognitive impairment. Well, it did work, and it's incredibly shallow thinking to think that just one thing is going to change everything. Can we stop that now? Can we be a little more holistic? At least think about 2 variables? They illustrate the importance of interaction in nutrition, hence the key role of dietary patterns. So does anyone actually have this in their labs? Let's look. So what it actually looks like for most people. This is a page, first half and second half, and I arranged it by the highest homocysteine level to the lowest homocysteine level. And there's another page coming of maybe about 14 people that I randomly chose that I've seen. So we did, this is the omega-3 6 panel, or the omega panel. Okay, so we see they have a 17 for one. Actually, I've seen 25, even higher. And here's their glucose. We're going to be talking about glucose coming up. Here's your omega-3 6, omega-3, and the risk, and then there's inflammation, C-reactive protein. So what do we have? We have high homocysteine, pretty okay glucose, pretty high ratio, moderate. He's moderate omega-3. And so this number, the risk based off the omega-3 index, these two columns, rows go together, it's moderate. He could have more. It would be better if he had more. And obviously he needs to take his B vitamins and he would really get his risks down. But as it stands now, he doesn't have much inflammation, but he has a high risk of developing cognitive impairment and going on to be full-blown dementia and perhaps even Alzheimer's. Here's one that was even higher. So here's high homocysteine, high glucose, high ratio of the 6-3, low omega-3, and so consequently he has a very high inflammatory risk, very high inflammation. It's CRP. So he is, if he doesn't change, he or she is destined to have cognitive impairment, probably full-blown Alzheimer's within the next 10 years. And here we go on. So we look across the board. So now let's look on the lower side. Okay, same row, now we just continued. We're going down strictly by homocysteine, 10 to 6. We're seeing this is now getting to be in the moderate range. Technically, homocysteine, I say between 5 and 7 is the sweet spot, so they're all high by my standard. Glucose is a little bit high. He has good high omega, he has a good ratio of omega 6-3 and good amount of omega-3. So his overall is low, inflammation's low, and his likelihood of developing mild cognitive impairment, dementia, etc. is moderate. He needs to get his glucose down, as we'll talk about in a second. He needs to have his B vitamins to get his homocysteine down, but he's doing fine. He or she is doing fine. And that's how you look at this. These are the labs, and they are not expensive labs, so go get this done. Okay, well, what about alcohol? Alcohol consumption and the risk of dementia, 23-year follow-up of the Whitehall 2 cohort study. So what that is, that was a big study. I'll get into some details later. I'm not going to outline it, but there's a lot of people. A lot of people they go through, they follow every couple of years and go back and visit them and see what the data is. And then they spend 2 years crunching the data to put it out in these reports. It's very impressive. So what they found is that there is a sweet spot. This is where you've heard people talk about 14 units. You're allowed 14 units of alcohol. We'll get into what a unit is. But greater than 14 units per week is going to increase your risk of dementia, Alzheimer's, etc. But less than that is fine. But abstinence, so not drinking any alcohol, increases your risk of dementia. Whoa! And that's why people love this particular study. It gives them permission to have alcohol. But it's a little more complicated than that, and I can explain why that is. But I wanted you to know that when people talk about all alcohol is bad, let's get into it. Okay, so the risk of dementia was increased in people who abstained from alcohol in midlife or who consumed greater than 14 units of alcohol per week. This was the study, Whitehall 2 study, ongoing cohort of men and women, originally employed in the British service in London offices, a total of 10,000 people, 7,000 men, 3,000 women, etc., ages 35 to 55. It's huge. One of the biggest studies really ever done, and it's ongoing. So they're taking them right through to as long as they're going to live. So it takes place about every 4 or 5 years, and each wave takes 2 years to complete. So what's a unit of alcohol? A unit of alcohol is 8 grams or 0.3 ounces of pure alcohol, i.e. 100% alcohol, 200 proof. It takes an average adult around an hour to process 1 unit of alcohol, so there is none left in their bloodstream. So that's what they're keying it off of. Examples, wine. Standard glass of wine is 175 milligrams, which is actually 5.85 ounces. So that's a little over 2 units. So you can have a hefty glass of wine, and you can figure out, drop it back a little bit, so you can have your wine, 1 glass of wine, big hefty glass of wine, not as big, it's moderate they call it. Having 6 moderate glasses of wine, 175 milliliters of 13% wine in a week will take you to the limit of the low risk guidelines, 14 units. 14 units at 6 pints of 4% lager beer, at 6 glasses of, there you go, 5.8 ounces of wine. 1 ounce equals 30 mils. Examples of alcohol, here you go. Let's go to wine over here, as we were just talking about. So how much does 1 unit of alcohol? If you're having 1 unit of wine, that's 2.5 ounces. So it's about obviously half as much. So it's an interesting comparison of what is it you drink and so on and so forth. It's the moderation. Now let me tell you why that's even a thing. And now the bad news. Alcohol flushes your vitamin Bs from your system. We need B vitamins to manufacture red blood cells. A lack of B often results in anemia, and this makes a person feel weak and tired. So now we're talking about alcoholics that have depleted their B vitamins. Low B12 affects our mood and many other crucial brain functions, as we've talked about. Low levels of B12, B6 have been linked to depression. Drinking alcohol regularly for more than 2 weeks decreases B12 absorption from the gut. So you've now stopped your ability to absorb, even if you're having appropriate food, it's now compromises its absorption. Vitamin B deficiency has also been linked to poor response to antidepressants. In other words, people are drinking because they're depressed, and their antidepressants are going to work even less likely to work. Evidence suggests that people with depression do better in treatment with higher levels of B vitamins. So new rehabs, it's for addiction in general, by the way, and we're going to get into that in another video, have to do with methylation, so on and so forth. B12 deficiency increases homocysteine, which may exacerbate depression. Many alcoholics are often deficient in B3, known as niacin, and some people swear by just taking niacin stops their drinking alcohol completely. So back to where we started, how B vitamin deficiency leads to brain atrophy, shrinking, and cognitive impairment. This takes us back to right where we started, the higher plasma homocysteine. So drinking depletes your B vitamins, elevates your homocysteine when in excess, right? Excess, beyond 14 units or all at once. Why is it that abstainers, those who don't drink alcohol, increase their risk of Alzheimer's, and why is it some alcohol actually decreases? So having alcohol decreases the risk to a point, and then it increases. So this is all about B vitamin depletion now. And the thing about alcohol, your body considers it a toxin. When you take alcohol, your liver has to process it immediately. So it does two things. It stops producing sugar completely. It stops releasing any form of glucose, so either through gluconeogenesis or it has to focus on detoxing alcohol. But it also increases your ketones, and your ketones feed your brain. So what we're seeing here is the alcohol dropping blood sugar levels. Okay, so the alcohol drops your blood sugar levels. That's a known. For those who know about ketone or ketosis, you'll find that if you have a drink and you're in ketosis, suddenly your levels go up. That's just known. It's not a trick or anything, but you might want to know that. Some people even feel it. So those who are teetotalers, I guess they're not teetotalers, they're low consumers of alcohol. When they have alcohol, their blood sugar goes down. When people have too much alcohol, what happens? They pass out. Why are they passing out? They're passing out because their blood sugar has gotten so low. So that's the effect of alcohol on the liver, stopping production of glucose through gluconeogenesis. And so suddenly they get too tired because they're not getting enough blood glucose. They're getting some ketones, so they're not in risk of dying, but they're going to fall asleep. So now let's go to, here we go, cognitive decline associated with metabolic dysfunction, specifically insulin resistance. This is such a big topic. We're going to go over this in another video, but bring in other specific connections such as methylation, genomic mutations, and choline deficiency. They were just too much to add to this. I want to show you that normal blood glucose is associated with, so high normal blood glucose is associated with decreased brain volume, shrinkage, cognitive performance decline in the 60s, decreased gray matter in the frontal cortex was associated with poor cognitive performance, executive function, information processing, speed, and language. So they're just starting to lose it. That was in 2013. So high normal glucose, what the heck is that? Here we go. Is a risk factor for dementia. So this is the curve. So this is your glucose numbers. This is your 100, 110, 120. If you're a measured diabetic, it would have to be beyond 126. So that's why this is all pre-diabetic. So 100, if your average fasting blood glucose level is over 100, that's going to put you at risk. As an independent factor, it's going to put you at risk for developing cognitive impairment, dementia, Alzheimer's. Below that, you get a benefit. But look at this. You don't have to get below that by much. If your fasting blood glucose is 90, this takes it to 90, you get a drop of a decrease of 25% in the risk factor of developing it. So it really behooves you to understand what your fasting glucose is. And I would also take it with insulin. That's neither here nor there, but you should do that always together. So a much lower risk. So anything above 100 is a fasting, So consistently above 100, you're at risk, but there's things you can do. And there's the higher risk. That's what I wanted you to know. And that was New England Journal of Medicine in 2013. Notice that below 100 for glucose levels had a lower risk of dementia, coupled with the abstinence of alcohol increases your risk for dementia. What I mentioned before. Why? For those who don't already have low blood glucose levels, right? So there are those people above the 100 line. Now they have an alcoholic drink, and what happens? Their glucose comes down. So as much as it does bad things for those 14 units, it gives them time in which their blood glucose is now in a much safer range. So it actually helps their blood glucose for that. So there's the moderation, and there's the benefit that you get from that. So for those that have the higher above 100 range and they have alcohol, they're going to see it drop down, and suddenly they now have good blood sugar numbers. Alcohol will actually lower one's glucose levels. It's due to what is referred to as oxidative priority. We've talked about that in former videos. The liver stops making glucose via gluconeogenesis, increases ketones, while it focuses on breaking down alcohol exclusively. Okay, next up in this topic, insulin resistance, ketosis, the connection of methylation, genomic mutations, and choline deficiency. Talk to you then. Hi, I just wanted to add, if this is something you're interested in going, what are the causes of dementia, Alzheimer's, cognitive impairment, mild cognitive impairment? We're going to have a number of videos coming up that I'll keep you posted on. Absolutely fascinating, whether you're thinking for yourself or you're thinking for your parents or you're thinking for friends that would receive your advice in a positive way. You might be interested in this particular video.